Right. So I think we will begin in that case. So good evening, everyone. Welcome to the BOMSS Journal Club this evening. It's the 9th of July. Thank you for joining us. So my name is Mo. I'm one of the surgical trainees in the East of England, and I'm your new trainee rep, taking over from Ahmed, who was outgoing last month. It's my pleasure to introduce the Somerset team today, who are going to be taking us through two very interesting papers. I'm going to introduce Miss Hollyman and Mr. Noble from the Somerset department, who have brought with them Ahmed Arber and Mike Richard. So I'll hand over to you, Miss Hollyman, and thank you very much.
Okay, so the first paper we're going to discuss today is entitled Effectiveness of a Nurse-Led Telecare Programme in the Post-Operative Follow-up of Bariatric Surgical Patients, which is a quasi-experimental study. We've got our nurse specialist who supports us on the world, Mike Rickard, who's going to go through the paper and pull out the salient points for us.
Okay, so it's a critical appraisal of the nurse-led telecare after bariatric surgery. As Ms. Holloman said, this is the effectiveness of nurse-led telecare program in the post-operative follow-up in bariatric surgery patients. And that's a study which was done in Spain. So why this paper and why now? So get it right first time. Early ED visits after bariatric surgery are quite costly, and this is to avoid cost and pressure. So NHS England has got a virtual ward push. And based on that, the Somerset ICB are trying to get a digital follow-up with more or less success. And then it's an interesting review practice outside the NHS, so hence this paper. The study synopsis is a quasi-experiment, which means it's evaluated an intervention without randomization. The setting is two Andalusian tertiary bariatric centers. During COVID, where we all were looking at different ways of doing things, so January 2019 to June 2020, so 18-month period. Intervention was they offered a 24-hour phone/WhatsApp helpline, plus one proactive call a day to the patients. The sample size is relatively small, mainly probably due to COVID. 161 intervention group was 81, control group was 80. And the outcome was that the 30-day ED attendance, they're looking at that to improve, plus the readmission and reoperation rate. So bit to the study. So the demographics were, so in the control group, like I said, is 80, 71% were female, 28.7 were male. The average age was about 45, and the BMI of 46. In the other group, in the intervention group, there's 81 patients, 60.5% were female, the 39.5 were male. Average age was slightly lower, and the BMI was slightly lower, but not by much. So the surgical procedures they offered was a single anastomosis gastric bypass in 108 patients, so the majority of the patients. They offered a laparoscopic vertical gastrectomy on 24 patients and a simplified gastric bypass in 23. During that period, they reported in the paper there were no intraoperative complications during the surgical procedures. So the intervention was the control group had oral and written information. Their protocol is liquid diet and supplements for 7 days, and then a semi-liquid food diet for 3 weeks. They explained how to inject the enoxaparin. No, they didn't explain how much the dosages were. And then appointment for nutritional clinic in 30 days on the day of discharge. And if they had any problems, they need to go to their primary care doctor. So the intervention group had basically the same, apart from the last spot where they were told to contact the specialist nurse, which was available 24/7 and or via WhatsApp. They had all the details then given to them in written, like it says. So the telephone consultation in the intervention group were in the morning, and they classify morning till 3 p.m. That's a bit late personally, but yeah. They had about 194 calls, so the majority of them, over 50%. In the afternoon, between 3 p.m. and 11 p.m., they had 150 calls. And then during the night, which was between 11 p.m. and 7 a.m., they had 13 calls. Over about 360 calls, basically. So the results were that in the control group, they had 24 ED admissions during that time, which meant, for various reasons, fever, vomiting, wound concerns, constipation, dizziness, and drainage problem, which suggests that they have sent patients home with, in the paper, that they sent them home with a drain in situ. The readmission after being seen in ED, so they went to ED with a problem, were then sent home, and then 3 of those came back with an average hospital stay of actually 23 days. And unfortunately, in the paper, they haven't really talked about it a bit further, actually. The intervention group, they had 4 ED admission, 3 due to abdominal pain and 1 other, and again, it's not specified. The readmission rate after the ED were 4 patients. However, it was a shorter stay with 6 days, and 1 needed a surgical re-intervention, and it's not explained what they actually did. So the summary of the outcomes were that the ED visits were in the control group 30%, were this 4.9. The number to treat was 4, actually. And then 96% of the contacts were resolved remotely, which means they phoned or WhatsApped in and they could sort it out there and then. The internal validity, its allocation by hospital is not randomized, so selection and center bias, basically. There was no adjustment made for the surgical mix or time trends. And consecutive recruitment, and they had a clear clinical question: can we reduce the ED admissions within the first 30 days by offering this new service? Exposure, single unblinded nurse. So the nurse who were actually on duty, they had the equivalent of like a specialist bariatric training according to their standard and guidelines. The outcome, like I said, was to reduce the ED attendance, and they used the ED records to see what they actually, what was actually done to them. The patient reported outcomes are missing, so there's no follow-up with that. If the patients were actually happy with the service they offered, and they completed the follow-up within 30 days. Statistical adequacy. So the CI is absent, which basically means that because of the paper omits the clinical confidence intervals, we're not really sure what the real effect is, and only therefore that some effects exist, basically. So we're not really sure, yeah, how it works. Well, yeah. Mixed effect or ITS would improve inference. So it's basically, because it's a quasi study, they treated all patients' observations as if they were independent snapshots, and they're actually clustered by hospitals and embedded in all times that might have been changing for other reasons. So it's a mixed model would have been probably solved the problem, basically, so to give a bit more statistical adequacy. The external validity is Spanish 24-hour phone. They were offered 24 hours, 7 days a week, WhatsApp for 30 days. In the UK, normally, so I spoke to my colleagues who predominantly do the follow-up and stuff. We offer office hours, like probably most centers, and dietetics call. So in Somerset here, we're available 9 till 5:30. They can leave messages, and we normally pick it up the next day. And then we have got the option of getting patients into the SU triage area, which is our ambulatory service. WhatsApp is obviously not NHS approved, so digital inclusion issues there. Cost and workforce. So the paper hasn't actually addressed any cost analysis at all. It's obviously quite cost intense. So looking at, for example, within the NHS, 24 hours agenda for change, there would be a band 6 or 7. So you're looking at roughly 180K a day per 150 cases. So that would be in Somerset, because we're doing about 150 cases a year. And the question is, does the ED avoidance alone offset the cost? I don't think it does, but it needs probably more an economic model, basically. And then potential access to hospital at home, which is we're trying to get patients trying to stay home and not have hospital admissions. Unfortunately, the model in Somerset or within Somerset NHS Foundation Trust didn't really work for surgical patients. Looking in the future, I mean, research possibilities are you could do a cluster RCT or step wedge evaluation. Needs to have embedded cost utility and obviously process evaluation. You could obviously have a look at the NBSR register data and see obviously if they had any surgery or any problems regarding their surgery, then it should be obviously registered there. And then address digital inclusion, which is the NHS is trying to do for the last few years and is proven difficult, I guess. So in conclusion, large reduction in 30 days ED visits, but designed limits certainty, and the cost of the model seems positive, but could be adapted if that is something we would do. So brings us to the discussion questions. 24-hour service versus extended day service, is it efficient? How do you capture the patient experience and the digital equity? And then is the number to treat justifies commissioning? Well, does it set off actually having 3 or 4 band 5, band 6, band 7s to actually would offer that service? And here are some references, and that's me done, I think. And
Okay.
I'm open for any questions.
Thanks. Yes, thanks, Mike. It is quite an interesting paper. I'm personally impressed that they've managed to put this resource into their hospital when they've only actually managed to put 80 patients in over an 18-month period. It does seem like a massive resource, especially to have someone available overnight when only, less than 4% of the calls have been overnight. Have you got any comments on that?
No, you're absolutely right. And I think during COVID, because it happened during COVID, I wonder if they were happy to, spend some money to see if that actually is working. Interestingly, talking to my colleagues, I think we hardly have any ED admissions from our bariatric patients. So yeah, it's really cost intensive. I was actually quite surprised, and they haven't gone further into that. And it would be interesting to see if they actually have introduced this model at all.
Yeah. I mean, as you've highlighted, and I'm sure probably other trusts across country are similar, where we are maybe give more autonomy to nurses in this country than maybe in other places in Europe. You've obviously got experience of working in Germany, so maybe you can reflect on that. But it may be that actually it's just novel to have the option of picking up a phone, and it may be that actually what we offer as a kind of 9 to 5 type service is actually sufficient to keep most patients out without having to go too fancy with WhatsApp messaging and complete 24/7 cover. What do you feel about that?
Yeah, again, I talked to my colleagues. We obviously got 2 bariatric specialist nurses who deal with patients post-operatively, and they feel that is adequate. It depends on what your center is offering, I think, isn't it? I think within Somerset, within Taunton, we have obviously the SU triage, which is readily available to us. So patients don't necessarily have to come to ED. The autonomy here is that I think my colleagues and I actually make the decision to, okay, come to SDU, we do some blood test or whatever we need to do. The other thing is we rarely send a patient home with any drains.
I think it might be a language issue because it says drainage rather than drains. So I don't quite know I don't completely know what they're getting at either. But no, when I read the paper, I didn't necessarily think it was a drain.
Yeah.
Specifically. So I think there might just be some.
Yeah, there's something further down. I read it before we came online because I read it again, and there are patients they're sending home with drains in situ.
Okay.
Yeah,
it does seem unusual.
But it's not really fully explained.
No.
It seems a bit strange, but
Yeah. So I
I don't know.
suppose
I'm not a
one
surgeon.
thing that is important, I suppose, to highlight with the comments you've just made is I think you used the word ED admissions, but actually it's
Mm.
ED attendances, and the actual
Attendance. Yeah,
overall number of admissions was low between both groups. But
yeah,
it's obviously just burden on the emergency service. And
yeah,
although we do take a lot of phone calls, we do often reassure patients by allowing them to come in a planned way
yeah,
to the hospital for assessment, so they would be classed as attendances or whatever. So I mean, our number probably is higher than we would personally estimate, and again, I don't know what happens elsewhere in the country. So
yeah.
I can see there's a question on the
Mr. Noble
chat.
has hand up.
Yes, I see. Okay, sorry, I can't see you on my screen. Go, Mr. Noble, let Mr. Noble speak.
Oh, really? Okay. No, well, I mean, yeah, I mean, the data you presented suggests that the 24/7 service certainly is not cost effective, and most of the queries that come from our patients can wait till daytime, and that's what this study shows.
Yeah.
So where do you think, where would be a quick, cheap win, as it were, if we were to adapt? And our post-operative service and access to bariatric nurses is probably similar to most trusts in the UK.
Yeah, yeah.
9 to 5, 5 days a week, and it'll cover the majority of problems. But if you were to make an improvement, what would that be? Thinking cheap.
Yeah. I think probably on the
And
discharge letter, I think give them access to the SU triage, so they actually be seen straight away by a surgical team potentially, which we don't offer because I feel at the moment we probably don't have that many people or many patients post-operatively who actually have that many problems. That might be an option. It's
what did our specialist nurses think about WhatsApp?
I think generally they're probably happy, but again during daytime. Yeah.
Yeah, no, absolutely.
Yeah. I think they would. Yeah. I think they would be happy.
The majority
fully,
of people under the age of 40 don't use a telephone for actually telephoning anybody, do they?
no, that's very true.
Well, that might be an interesting avenue to explore.
Okay, we've got one question from one of the people watching the webinar. So you've shown a significant reduction in ED visits. Did you assess whether this had any impact on patient satisfaction or anxiety levels? And then do you want to answer that first? There's a few supplementary bits of question.
So they haven't really addressed that. So there was no patient satisfaction survey about it at all. And that's, I think, one of the slides I did say that they haven't addressed that at all, to be honest. Problem also is that I think it was during COVID time, so
I think you are saying that, Mike, but it started the year before COVID, so it didn't set it. It may, in terms of the recruitment, etc., it may have affected the number of operations they were doing, but I don't think it was set up with that in mind. It's obviously been done before that. Okay, so while ED visits were reduced, admissions and intervention rates were similar. What does this tell us about the clinical significance of your findings?
It didn't make any difference in that respect, actually.
Yeah, but I mean, that's good. I mean, ultimately, it means that to me, the people who needed to get through do get through, but the problem is there an easier way? And it's obviously probably easier for the patient to have a hotline to somebody to phone, but actually it's if you are literally funding it with nurses 24/7, then it is probably more cost effective to allow those patients to turn up to ED. But it sounds like the halfway house is what we offer, which is that they have good access 5 days a week to be supported. And then the final comment was about was there any economic analysis done or planned? But I think you've already.
No, there was none actually.
Yes,
none whatsoever. I have to say, I was quite surprised about that because obviously cost is usually in the forefront of our mind. Most things we do,
yes,
or length of stay actually. So
yes,
so none of these things.
Okay. I think that's great. There doesn't seem to be any more direct questions, so I don't know if we go over to the next presentation.
Okay, right. Next we've got Ahmed, who's our current fellow in Taunton. He's going to present a paper which looks to explore cost comparisons between surgery and GLP-1s in the States, particularly.
Thank you very much for the invitation to the BOMSS Journal Club. I'm the current bariatric fellow at Musgrove Park, and the paper today is a paper that's been written by a group in Tampa General Hospital in Florida. And they've done a cost comparison between GLP-1 receptor agonist and bariatric surgery. And I think the main aim was to see what is the break-even point between the two main procedures for bariatric, which is Roux-en-Y gastric bypass and sleeve gastrectomy. In terms of the background for the study, there is a rising prevalence of obesity in the United States, but that is the case worldwide. And what I find quite staggering is about 49% of people are classed as obese in the United States. Of course, GLP-1 have joined the ecosystem of weight loss management, and it is gaining popularity both in North America and worldwide. Of course, there is a big question. Bariatric surgery remains the gold standard for weight loss and maintaining that weight loss. However, the big question is the financial cost is a key concern. The objective of the study was to compare the cumulative cost of GLP-1s. And they looked at 6 different GLP-1s. Some of them, they have been FDA approved for weight loss, and some of them not, versus bariatric surgery, and namely 2 procedures, Roux-en-Y gastric bypass and sleeve gastrectomy. And what they meant by the break-even points is when the accumulative cost of the GLP-1 or the bypass, they surpass each other. And the ultimate aim was to support patient-provider decision-making. They done only a cost comparison model. They looked at the primary cost rather than the complication cost or complication of GLP-1 or complication of surgery itself. And they looked at the US data. The surgical cost was adjusted to inflation, and the cost was taken from a 2015 paper. And the drug prices, they were obtained from the national data. And they've done a Microsoft, fairly a simple Excel modeling. And as I mentioned, the GLP-1s, they looked at all of the GLP-1s, all 6 of them that were available in the United States. And they looked at the cost of each one of them versus sleeve gastrectomy and Roux-en-Y gastric bypass. I think what's interesting is that they haven't used any other outcomes to compare. So they assumed weight loss with all of them, and they all successful in the weight loss. And they mainly concentrated on the cost associated with this. What's interesting is that the cost of sleeve gastrectomy is about $14,000 US, and a Roux-en-Y gastric bypass is about $17,800. The GLP-1, the average was about $1,305. And it's interesting that these costs are quite different in the UK, and they're much lower in the UK, both for the GLP-1 and for the surgeries. The main findings of them was that the break-even point for Wegovy was 9 months with the sleeve and 11 months. So beyond 9 months, if you're on Wegovy and you're trying to lose weight, you probably are spending more money than if you've gone for a sleeve or you've gone for a Roux-en-Y bypass. And the same thing was with all the other GLP-1s. None of them really had a cost that was less than the one-off cost of a Roux-en-Y gastric bypass sleeve by 2 years. And this is the graph from the paper. And if you see the dotted lines at the bottom, the top brown one is the Roux-en-Y gastric bypass, and the bottom one is the sleeve gastrectomy. And all the other GLP-1s by 24 months, in actual fact, by 2 years, they surpassed in terms of cost for the patient. I think the strength of the study is timely, it's relevant. I think GLP-1, it is fairly new modality of managing obesity. Of course, there is a lot to be done in terms of data synthesis and understanding where this GLP-1 fits in terms of weight loss. The model was fairly simple and intuitive model. It's not really a cost-effective model. They felt in the paper that it is helpful for patient counseling to give them an idea about how much money they will be spending. And they felt that this addresses the real-world pricing and trends in the United States. To come back to the methodological limitation, I mean, it is all good and well to look at the cost data alone and compare cost. However, the reality of any meaningful modeling, especially like from a UK perspective, based on the National Institute of Clinical Excellence, NICE, is to do an economic model where we look at the utility associated with the health state achieved with an intervention versus the cost associated with that, and look at the lifetime cost of that and the lifetime quality adjusted life years achieved for the patient. One of the really main problems with this paper is they really didn't look at the adverse event of the cost inclusion. They haven't looked at reoperation, they haven't looked at complication with GLP-1 such as pancreatitis. And I think part of the reason for that is because we don't have much data on that, other than the primary trial data for GLP-1. Of course, there is data on the Roux-en-Y gastric bypass and sleeve gastrectomy. One limitation is, of course, it's a US-centric pricing. The pricing in the UK, they are negotiated very differently, and they're much cheaper, the GLP-1s in the United Kingdom than they are in America. But on the same token, a bypass in the UK, based on the costing data from the biband sleeve study, they are much lower than the US data. And of course, one of the downside with the paper is it assumes continuous adherence, and papers coming from the States, they suggest that the adherence could range anywhere between lack of adherence between 16% to 50%. And of course, the most promising trial data, they talk about 6%. So it is all good and well to look at the costing of the procedures and look at the cost of the GLP-1 and look at the difference, but also what happens to the patient that stopped taking the medication. What about the patient that the procedure, they don't lose weight with the procedure, or they regain the weight after a few years? Of course, there is also clinical limitation in terms of applying this paper. It doesn't really account for comorbidities. I think one of the aims of a major bariatric surgery in somebody who's young is diabetes remission. It also ignores the long-term follow-up costs with surgery. The same thing if we look at the UK model, the long-term follow-up costs with GLP-1. And of course, it is very difficult to make any personalized patient-specific scenario based on the costing data. And of course, if we look at the UK side of things, the NHS bariatric surgery is funded by the NHS within England and to a lesser extent in Scotland and Wales. However, looking at the numbers done in the UK, it's less than 1% of the patient eligible for the procedure. GLP-1s have been approved. 2 of them have been approved in the UK. One of them only limited for 2 years approval, and the other one unlimited. However, there is big questions about funding and where the funding is going to come. Of course, there is a huge interest between public and patient interest in GLP-1, and I think the paper supports advocating for earlier surgery. However, I think there is a lot more data that is required to build up any meaningful model to help the patient make a more meaningful decision rather than just looking at the cost of the costs. In conclusion of what the paper have said is GLP-1 often surpass surgery costs within 1 year, maybe slightly higher for sleeve gastrectomy. They felt that bariatric surgery offers more durable outcomes, but of course also we need to remember that it was a surgical team that wrote this paper, and they think that the financial data supports earlier surgical referral. However, I think if we are to redo this study in the UK to build an economic model, we probably need to look at the quality of life data, also look at the costing data, the long-term complication, the different relevant health states for both GLP-1 use and bariatric surgery. I mean, some of the discussion point that I thought about is, should we recommend surgery earlier on cost ground? And what is the role of GLP-1, both pre-operative and post-operative, or on its own for management of weight loss? And how should we start generating that data? And how should we inform that conversation with the patients if they get referred to tier 3 and there is availability to GLP-1, or referral to tier 4 how should that discussion happen and who should have that discussion with the patient. I think that's me presenting this paper. Thank you very much for the invitation, and of course, looking forward to the questions.
Thank you very much, Ahmed. That was really beautifully covered. We have got quite a few questions that have come up in the chat, which I'd just like to relay to yourself to start off with, if you don't mind.
Sure.
Some of it I think we've sort of already touched on a little bit in your discussion. So the first question is, the study suggests surgery becomes more cost effective by 12 to 14 months, but doesn't consider quality of life. Should that limit how we apply its conclusions?
I mean, I completely agree with that. I think any meaningful, the cost that we're giving towards anything, what we're gaining in return. And of course, we have an accepted model in the UK. It does have its own limitation, which is the quality adjusted life years that has been adopted by NICE guidelines to assess new technology and new medication. And of course, I think for any meaningful way to answer this question, you have to specify your health states. So, for instance, somebody who's obese with diabetes, a different health state would be post-operative and remission from diabetes. And this has to happen. And once you have defined the health states, you have to find utilities and quality of life data that you could attach to each health state, and then the cost associated with it. And I think, of course, health economic models are quite useful in the sense that if we don't have enough data, we can make reasonable assumption based on the best available data and give an answer. I agree with the person who asked the question. Of course, I don't think cost on its own is valid enough for us to recommend something or not recommend it. I think what's important is we pay huge sums of money towards the cost of healthcare. So we need to know what we're buying on behalf of the taxpayer, what quality of life we're buying for the patient.
Okay, thank you. The next question sort of that's come up is, so do you believe that there's a risk that insurers or health systems might misuse such data to restrict access to GLP-1s in favor of surgery, even when the patient might prefer medications?
Again, like insurance companies would do what they could to improve their revenues, so would be the pharmaceutical companies. And I mean, if you look at the UK, there's been huge lobbying of the government to adopt Wegovy. The way NICE approved Wegovy or Manjura was unlimited. It didn't limit it to 2 years. But there was no, one of the downside of NICE guidelines is who's going to fund this and how this is going to roll out. How do the ICBs going to cope with the cost implication of providing this? I mean, I looked at the NICE guidelines for the GLP-1s, and it's really interesting to see that in the UK, based on the definition of guidelines and the model that they had, they think that we have about 4.9 million patients that are eligible for GLP-1 or surgery. And that's a staggering number. And year on year, this number is going to increase. Could the government fund such a big project and fund all of these people to have this? Where is this money going to come from, and what does this mean for bariatric surgery? I think what's important, I mean, again, I might be veering a little bit away from the paper, but I think what's important is understanding obesity is a major, of course, obesity is a major public health problem. Where does the GLP-1 actually fit in? Should some patient be eligible for GLP-1 first before they come for surgery to make surgery much more safer, to make surgery safer? What about patients that gain weight after surgery? Should they be given a trial of GLP-1 and see if that changes their behavior? I think there is a lot of questions around where GLP-1 fits in the pathway. And I think there will be lots of different models across the country about how this would fit in. But at the moment, nobody have the real answer. So we need to generate the data and collect the data to inform the way different ICBs or different health authorities would deal with the new GLP-1 and its management for obesity.
Thank you, Ahmed. I can see that Ms. Holliman's put her name next to one of the questions. So I'll read out the question, and then if we can ask for Ms. Holliman.
Oh, sorry, I was just ticking the boxes, doing the admin, but it's fine. I mean, yeah, the next question was, does the analysis support the idea of using GLP-1s as a bridge to surgery, or does it make the case stronger for upfront surgery without delay? I mean, I think all of us would feel, you know, as surgeons, that we should be offering surgery as soon as people are physically ready and able to do it, because the benefits are going to be more long-lived. You know, if we can get to surgery earlier, especially in patients with diabetes, etc., the chance of remission are much better. So, but the problem is with all these things, we're obviously limited by our resources and capabilities, and I don't think there's a great deal we can suddenly do to speed up the path to surgery. I don't know. I mean, I personally think probably the GLP-1, the sort of wave of GLP-1 interest may actually spark a wave of surgery interest, because people who never would have considered it before may sort of almost see it as a yes, as a bridge to get there to something they wouldn't have considered. So it may be that some people will present earlier than they would have done without. But I don't know, Ahmed, if you've got any
I mean,
further
again, this
comments.
is it also poses an ethical question. If you started somebody on GLP-1 and they lose some weight and then they stop it and they regain the weight, they had access to weight loss services and they'd like a solution. Would this increase the demand for bariatric surgery rather than reduce it? I personally think it would, because looking at the early data from semaglutide, I mean, I read a paper some time ago that the adherence was less than 50%, because I think what surgery does, it again, I don't want to make any big claims, but I think there is a lot more data for us to get from real life data. When I spoke to Eli Lilly representative, they starting a study in Manchester to look at all of the different complications associated with GLP-1 and also look at the weight loss associated with it. I mean, because and they're trying to look at people who get the GLP-1 through the local authority or the ICB versus the ones that purchase it. And I think it would be interesting to see, because the way it's been approved in the UK, it's not just been approved that you take the medication and it's going to be like a magic wand and you're going to start losing weight. It comes with a package, a dietitian, somebody to check your blood test, do a HbA1c, follow the patient up for a year to see if actually they're benefiting from this, make sure that they don't have a complication. If they have a complication, they understand where to go and where to seek help. There is a lot of big questions around GLP-1. Personally, I think bariatric surgery is here to stay, and it might expand as a result of GLP-1 because people gain that awareness that they have access to weight loss services through the NHS.
Right. Okay. We'll skip to one of the other questions. What are your personal views? So they've commented, excellent presentation. What are your personal views about bariatric surgery when the patent covering semaglutide and tirzepatide will finish in the mid 2030s and the medication can be made by different companies with cheaper prices?
I mean, this is completely. I mean, it is given that the GLP-1 prices will be much cheaper as we go, and there will be new GLP-1s in the market year after year. However, we don't know. Nobody knows really the impact of that long term on the ecosystem of weight loss surgery. As I said, the problem is very big. It's about 5 million people at the moment, and if we look at some of the reports by there was a white paper by the government before COVID, which looked at childhood obesity. There is a huge rise in childhood obesity, and they're likely to become obese adults if there is no public health intervention. Can we just give them GLP-1s? Would GLP-1 just solve the problem? Would we all be carrying a pen of GLP-1 walking around 10 million Brits? It's quite difficult for me to imagine that. But again, I don't know the future. If I knew the future, I would be able to completely and honestly answer that question. I think there is, of course, the I don't want to use the term, but I'm going to use it. Actually, the market is changing. There is new products, but the demand is very big.
Okay. Thank you very much. I think we'll take just maybe one or two more questions. So I'll just continue to read from the chat. And I think this is more of a comment, and I wanted to see what the panel thought of this. So there's a comment that says that I think giving a chance of GLP-1 in addition to diet could be better than going through major surgery for benign disease and not cancer. Can I get a comment from the panel members on that?
Yeah, I'll go first. Yeah, I
well-
definitely think it's a good choice for a lot of people, and we've obviously seen, you know, a massive amount of popularity for people sourcing this online. You know, so there is a massive appetite for people to dip their toe in the water and see what happens. And it obviously is a much bigger step to put yourself through an operation, rather than just, you know, try an injection for a couple of weeks and see if it works. So, you know, but we're not necessarily saying that surgery is the solution for everybody. It is a solution for a group of patients. But it will be interesting to see over time how it evolves and how the attitudes to both the medications and the surgery changes as things evolve.
Thank you.
Yeah, I mean, I was going to ask the same as of Ahmed, really, is where GLP-1s currently sit in his practice, and clearly at the moment there's benefit of patients at both ends of the spectrum. The fitter younger patients with less comorbidity, less weight to lose, there's a benefit, huge market. And on the other end of the spectrum, the high-risk patients who you really don't want to operate on, or you need them to lose weight before operating on them. But it's the middle ground where there's much to learn.
And just to add to Mr. Noble, I think having that option of GLP-1, it also means for the surgical community that surgery needs to be as safe as possible, and we reduce the complication as much as we can in our practice. Because there is an option. It's a benign disease, of course. So I think surgery will become even more safer. Patient selection will get better. And of course, surgery was never the solution to the obesity pandemic worldwide, because you can be offering millions of surgeries. There is no healthcare system that would be able to cope with the demand of that. And I think we will see a changing of the definition of the eligibility for patients and who's eligible for the operation.
Thank you very much. Thank you. I think in the interest of time, with just 1 minute to spare, I think we'll call it there. So I'd like to thank Mr. Rickard, Mr. Aber, Miss Hollyman, and Mr. Noble, and the Taunton team for coming along and giving us really interesting papers tonight to discuss. So thank you very much. And thank you to everyone that's attended. We will see you at the next Journal Club meeting, which the details of which will be sent out in due course. And I wish you all a very lovely rest of the evening.
Thank you.
Thank you.
Take care.